Just want to make sure. Okay, just wanted to make sure we're recording. So thank you everybody for joining us today. Welcome to another edition of Global Conversations. For those of you who don't know me, my name's Amber and I work with our individual donors and partners. Thank you for all of your support. We really appreciate it and we're just excited to see you here today. Today we'll have two wonderful speakers join us. They're program directors in San Diego and Botswana, and they're working to advance health for women and girls. But before I introduce you to them, I just wanted to quickly let you know how the format will be today. We'll have about 40 minutes total, and the first 25 or so will be presenting, and then I'll ask a couple of follow-up questions, and then after that it's really open to all of you. If you have any questions, you can put them in the chat at any time and we can ask them at the end, or at the end you can also pop on your video or just unmute yourself and ask some questions. During the presentations and the questions, the first part of the questions, if you could just please stay on mute, that would be great, because as we just said, we are going to be sending it out, recording it and sending it out for others to watch. So we want to make sure the audio is nice and clean. But now, without further ado, I'd love to introduce you to our wonderful guest speakers today. We have Thandi Tumelo. She's our program director from Global Communities Botswana. Thandi joined PCI, now Global Communities, in 2010. She's a behavior communication strategist who's worked in a diverse range of settings from corporate to humanitarian. She's a believer in the power of mentorship and that to make a difference, you must be the difference. She's also as 9 hours ahead of us, so we really appreciate her spending her early evening with us. Thank you and welcome, Thandi. And we also have Lisa Bain here today. She's our Director of U.S. Border Programs and Healthy Start San Diego. She's been with PCI, now Global Communities, for 10 years. And she's been working in different roles supporting Healthy Start. She began her career a while ago in the Peace Corps as a volunteer in South Africa, and she's been in public health ever since. She has over 18 years of experience designing, implementing, and evaluating health programs to achieve health equality, and she is very passionate about that. You'll hear that in her speech today. So thank you both.
Andy already has a question.
Again for coming today. Yes, go ahead, Andy.
Yeah. Could you repeat the names of the two individuals, because you spoke
Yes.
fast for me?
Oh, sure, of course. So we have Lisa Bain. Maybe Lisa can raise your hand. There we go.
Okay.
And then we have Thandi Tumelo. Raise your hand. There we
great,
go.
thank you.
Yeah,
Okay.
sorry about that. Thank you for asking. I try to get through it really fast so we can get to the good stuff. So, and now go ahead, Amanda, if you want to put up the presentation, and we'll have Thandi go ahead and take it away. Thank you.
Thank you very much. Good day, everyone. My role is pretty much to take you through what Global Communities is doing in Botswana. Next slide, please. So in Botswana, we are advancing health and working with adolescent girls and young women. Our women's health is her capital. Lessons from COVID-19 and other emergencies have taught the global community that when systems break down, girls and women are often the first to suffer. Next slide, please. In Botswana, around 2019, we began a gender-sensitive, age-specific, comprehensive sexuality education, activities, and service provision. And in doing so, we established safe spaces for girls and young women using female mentors. We then developed an evidence-based, age-appropriate guide that mentors could use within the safe spaces to guide, strengthen, educate, and link adolescent girls and young women to health services and clinical services. In doing so, Global Communities in Botswana, we support local organizations to provide these services in 8 districts within our country. Next slide, please. Now, one of the key challenges that our young women face and our adolescent girls is unintended pregnancies. And a number of these unintended pregnancies are caused by forced sex. And there's always a lack of access to sexual reproductive health products. Now, the problem is so compounded and profound because it is made even more significantly devastating by the fact that a lot of the young women who we engage with have actually indicated that they fell pregnant during adolescence due to forced sex, and that there's been multiple incidences of sexual violence within the relationship. This has resulted in early sexual debut as well as pregnancy. Next slide, please. So global communities introduced safe spaces that we are implementing within our DREAMS program. In particular, we have safe spaces, which we call fusion safe spaces, which is our combination of in-person and virtual safe spaces. And they've been designed to be able to reach out to adolescent girls and young women in the most rural communities. Lessons from previous emergencies have highlighted the need to safeguard health and well-being, especially for adolescent girls and young women. There's been a critical need to adopt strategies to enable essential health, HIV, sexual reproductive health and rights, as well as violence prevention services for adolescent girls and young women. And it's become even more important to now start expanding and scaling up these safe spaces within the communities. These safe spaces provide girls with the protective assets they need, especially in the reduction of pregnancy and sexual violence. We look at economic assets and building the capacity of girls with health assets as well, looking at their access to family planning and other services. Social asset building is also a key element of what we work with the girls to try and build, in addition to keeping them in school so that they can be able to have the education that they need. Now, when we started the project in 2019, that focuses on adolescent girls and young women, we managed to successfully meet 90% of the young women that we've targeted and provide them with the safe space services that we need. And in 2021, we managed to reach 81%, while in 2020, we managed to reach 94%, which told us that the model is effective and works, and it's able to provide not only safety nets for sexual violence, but also provide opportunities for adolescent girls and young women to engage and dialogue in a safe environment with their mentor and be able to be linked to clinical services and sexual reproductive health products. Next slide, please. Now, as we developed these safe spaces and started rolling them out in the districts that we work in, one key element is that more and more young women and girls started connecting with each other, which actually increased the walkable community for our young girls. They were able to discuss family planning and women's health in a safe, judgment-free environment. These safe spaces also tackled issues of mental illness and gender-based violence because they were able to establish safety nets and facilitate linkages to clinical services. The young women in Botswana are highly mobile. So because of that, we needed to create safe spaces which are both in person and also virtual so that they are able to access help and assistance whenever they needed it. Next slide, please. One key thing that we've learned is it's very important for us to be able to meet the girls where they are and to help them to be able to engage effectively and efficiently. And one key thing that we're looking forward to in our country is the expansion and the growth of this fusion safe space model so that we can advance health for women and girls. Thank you very much. And at this point, I'd like to hand over to my colleague, Lisa, who will take you through the project in San Diego. Thank you.
Hi, everybody. Thank you for being here. It is a great pleasure to be with you. You may know that we have several programs and a very long history in San Diego, but our biggest program is Healthy Start. And so that's what I'm going to share with you, but I'm just letting you know it's one of many things that we're doing here. So next slide. So Healthy Start is a project we've been implementing since 2007 in San Diego. And the goal is to eliminate disparities in infant mortality right here in San Diego. And we do it through significant partnerships and delivering what I like to call high quality perinatal services that every pregnant person deserves, but only some people get. We know we're so fortunate to live in the US where we have a pretty high standard of care and many services, but not everybody can access them. And so we're helping to resolve some of those issues. Next slide. So the first thing to know is it's really embarrassing, but the United States is behind other wealthy nations in terms of our infant mortality rate. Yes, infant mortality is still an issue, and maternal mortality in the US context. A lot of our global colleagues are shocked to know that this is still an issue, but it is. And, you know, we're trying to do something about it. Next slide. Even worse than that, we're kind of going in the wrong direction, at least in terms of maternal mortality. The numbers are going up in the United States instead of down, which is a big problem. Next slide. And then within all of those horrible outcomes, we know that some communities are significantly more impacted than others. They carry the burden of these high mortality rates. And in particular, Black and Native American populations are affected significantly higher numbers of both infant and maternal mortality. And I'll explain why Black is in parentheses soon, because it's not monolithic. Okay, next slide. So what are we doing about these horrible realities? Next slide. Well, the first thing to do is focus on the communities that do bear the greatest burden of these health disparities. So we saw in the chart that primarily Black communities have the highest rate, but particularly in San Diego, Black can mean many things. It can be African American. We have a very high number of what we call Black immigrants, recently from Haiti, longstanding population from Eastern Africa, including Somalia. So we serve a very diverse segment of the Black community here in San Diego. And we've also carved out space to serve other low-income populations who also wouldn't be able to access, you know, high-quality perinatal care services. So we're creating a large umbrella to really hit at those disparities and drop that statistic. All right, next. I can't say enough good things about our team, because our team are the magic of the program. They are from the communities we serve. We speak 5 different languages. They are trained childbirth educators, doulas, lactation educators, parent educators, and most of that training, I'm proud to say, they received, you know, in their time on the job from us. So, you know, we have selected people who are highly motivated community, I don't know if you'd say leaders, and given them the tools that are needed to go back to the community and provide key services. Next slide. And the type of services that we provide, well, first of all, we enroll families from pregnancy, and we continue supporting them through 18 months after birth, right? We are trying, the primary goal is to eliminate infant mortality. We enroll moms, but not only that moms, we also enroll dads and other partners who are supportive parents, right? We're trying to engage the whole family and lift the health outcomes for everyone. Our key service is health education, right? So from prenatal to 18 months, we're doing all sorts of health education on how baby is developing in utero, or, there are 6-month milestones, 12-month milestones, things like that. We deliver fantastic childbirth education and breastfeeding support, all direct through our team members. And then we have a key network of partnerships that allow our clients to access midwifery care, doulas, and mental health services. And those are, some of the services, right? If you're a Haitian asylum seeker who just moved to the United States, although there are wonderful hospitals, there are no wonderful hospitals that have childbirth education classes in Haitian Creole. Right? So we're aiming to deliver that. And if you're a new mother who happens to be Black and you would like to go seek breastfeeding support, you might find yourself among the only Black moms in a group. And so we're creating opportunities for people to access services in a familiar environment with people who look like them and speak their language. We do a ton of health and wellness screenings, everything from depression screening, intimate partner violence, or domestic violence, we call it, screenings, their access to food and housing. We do provide some resources, physical resources to keep babies safe, car seats, pack and plays, right? SIDS, sudden infant death syndrome, is still a driver of infant mortality here. And sometimes the barrier is just a safe place for the baby to sleep, or a car seat. So we provide those type of services. And then we also provide an element of what we call workforce training. So we're training from our same priority communities, additional childbirth educators, doulas, and lactation educators, so that we can start increasing the access to these services within the same communities. Next. Here, just reflecting some of the partnerships. These, we're Healthy Start staff. We're at the center of this graphic, but we do connect to partner organizations. We work with a midwife, one of the only Black midwives in San Diego, who has a birth center. We work with a counseling center, a group called For the Village. So we support training of doulas and then paying those doulas to provide support to our families during birth, including training the only, whoops, that's my timer, I'm talking too much. The only, for example, Haitian Creole speaking doulas in San Diego. And now recently we finally achieved the only Somali speaking doulas in San Diego. We're trained through our work. Okay, next slide. Here, just the next slides we can go through briefly, just some pictures of what our services look like. Here's a client with our midwife. Next slide. Here's one of our staff members doing childbirth education and coaching for labor. You can see here's a mom and a dad who were enrolled, military family. Next step, or next slide. Here's our midwife delivering a home visit to a newborn, and our health educator teaching dad about safe sleep for baby and the importance of breastfeeding. Next slide. Here's another staff meeting a family who knows what they're talking about. Next slide. I think that's it. Well, I'll stop there and let the rest come with questions, but thank you for being here.
I have a question. To the extent that the services we provide are limited by financial reasons, is there some possibility to lobby the state to provide more financial funding for those services?
That's a great question. And please know that we're always championing additional service, additional resources. One thing I'll share is that there are kind of some baseline services. And right now, because maternal mortality in particular is a hot topic in the United States, we are seeing increased funding levels, but we also see them kind of congregate to big institutions that do tend to overlook smaller communities like, the Haitian asylum seekers. So that's where, we will continue to advocate for forgotten and vulnerable communities, in the US context.
Thank you for that question, Andy. And also, there were actually a couple in the chat, so let's just jump to those first. And then if we have time, I can also ask mine. But I'm going to scroll up a little bit and ask a couple. We're going to start, Nancy wanted to ask to Thandi, can you give some examples of physical safe spaces? Where are they? What's the use of virtual spaces versus physical spaces? Is the usage of virtual growing over time? And I know, Thandi, you jumped in and answered on the chat, but maybe you could just go ahead and say it out loud too for everybody, since again, we're recording this. If you could answer that, that would be great.
No problem at all. Our in-person, or what we call physical safe spaces, are usually located in places where our adolescent girls and young women gather. And because the walkable community of a girl or their ability to gather gets less and less as they grow older, it then becomes a challenge. Right now, they go to places like schools or faith community buildings. And the reason why we've started integrating these virtual safe spaces, because we've designed a hybrid of in-person and virtual. And the reason for that is a lot of our out-of-school young girls are highly mobile because they're no longer in school, because they've dropped out, and they're not well educated. They're always moving from community to community, literally hiking from town to town to find economic strengthening opportunities, because most of them are even breadwinners for their families. So because of this high mobility, it was quite necessary for us to be able to connect with them and still be able to give them information and have somebody that they can reach out to if they need safety nets or they want to know about access to services.
Awesome. Thank you so much. And then our next question, Andy, you asked this one as well for Lisa. Why can't some women access prenatal care?
That's a good question. There's a huge number of reasons. In general, we're so lucky to be in California where we do have expanded Medicaid. So almost everybody who's pregnant does qualify for Medicaid. But if you just crossed the border as an asylum seeker, you probably don't know where to go for care. Housing is a huge crisis here. We see many of our clients struggling with such basic needs for housing and food that they just can't prioritize. Like, they know the clinic is there, but they miss the appointment. They can't get there because they're struggling with really basic needs. And then we also see people who go to the prenatal care, but the language barriers, even though those clinics do have something like a language line, they don't understand. And that's where we can play a very powerful role, because everybody who's enrolled in our program is, assigned one person. We call them perinatal navigators, and they're helping them navigate that healthcare system, document the questions. Okay, your doctor said something about blood sugar. Let's stop and talk about what that could mean. There's this thing called gestational diabetes, right? And then we can go on. So we're looping people back to strong systems of care to help them get more. But there's just a large number of barriers. I would say the first one is just clients who are struggling with really basic needs and cannot prioritize, their fourth prenatal appointment, for example.
Great. Actually, since we're already on that question, maybe Lisa, you could also expand on some of the other barriers you're seeing in San Diego and how you're overcoming them. And then we'll move on to Thandi and she can explain those as well.
Okay, well, I can't say enough about the housing crisis here in San Diego. Probably if anybody else is from San Diego, you're tired of hearing about it too. It can't be overstated. If I can tell you just the story of one client that I had the privilege of working closely with, kind of by accident. Her name is Nellie, and when I met her, we were having a health education workshop on Zoom, and she logged in. She was one of a few participants, and we were getting to know each other. So she is almost at the end of her second trimester, and she's in her car. And we do evening workshops to accommodate working parents, and she was eating dinner in her car while she was doing her laundry at the laundromat. And it come to find out that she was homeless. Actually, she had a car and she lived in the car, and all these things are going through my head. Here, we're supposed to be working on prenatal nutrition, right? How to have a healthy baby, right? It starts with healthy eating. How can I help this mom eat healthy when she lives in her car? Her dinner came out of the convenience store while she's doing her laundry. So, that all ties back to housing and the basic needs. So that's definitely number one. There's a happy outcome for Nellie, by the way. If I can just keep going real quick, her baby is now 1. What happened in that meeting, we kicked into high gear to really reach out to our networks and try to get her housing. The housing system is kind of fragmented. She got temporary housing from her last trimester until her baby turned 2 months. We were hugely grateful for that, because a temporary nest she could relax and have a place for her baby. And then after that, we were able to get her kind of by the skin of our teeth into a longer term program where not a program, a house, a studio apartment where she stays. Her baby's now 1. She's working. She doesn't have to worry about her housing. She recently took our doula training. So now she's invested. She's become certified as a doula and is in a position to help additional Healthy Start families and also be paid for that work, which is really great. But anyway, that's one big issue. And I already alluded to the fact that some populations are just totally overlooked, right? Because we have massive systems. It's hard to pay attention to some of the smaller communities that are here, like the Haitian asylum seekers, like the Somali community has been in San Diego forever. They're very well established, but zero Somali childbirth education, breastfeeding support. None of that existed until we started putting attention to those communities. And now, of course, we have a huge Afghani and Syrian population that are also just unable to participate in the big systems of care, except for at the most minimal levels. So I could go on a lot about paid family leave and childcare and things like that, but those are some things on my mind.
Thank you, Lisa. Yeah, it's interesting definitely to hear, in San Diego, again, you said this at the beginning, we're in the United States, people kind of take healthcare for granted here, and it's not equitable. So thank you for sharing that. And Thandi, same question to you. Maybe, I know in your presentation you mentioned some of the challenges and barriers, but maybe you could reiterate some of those for the audience.
Okay, thank you. I think one key challenge is that there's this assumption generally that if you build a clinic, people will access it. Especially adolescent girls and young women. But when you are struggling with adolescent pregnancy due to gender-based violence, it's not easy for you to be able to access services even where they exist. So that is why safe spaces are so critical, and they're just not enough of them. Adolescent girls do not have an environment where they can freely and safely talk about or even support each other to access health services. And this is a challenge, especially since there's so many adolescent mothers due to the gender-based violence and the sexual violence. So one of the things that we are doing to try and mitigate that is, and that's why fusion safe spaces are so key, because they are meant to try and increase the walkable community of adolescent girls and young women. It's because it helps them to be able to connect with each other, to support each other. There are cases where some of our female mentors, there's one case where one of our young girls told me that her mentor. She called her mentor in the middle of the night because she needed sexual reproductive health products, and she didn't know where to get them. And her family, she's living, she is the breadwinner of her family, and she's head of her household. She's like 17 years old. She's looking after her younger brothers and sisters and her child. And she'd call up her mentor because she was afraid to go to a clinic, because every time she went, she needs to pass by a bar where men would sit and hurl insults at her. So she needed her to come with her so that she's comfortable to walk the 15 kilometers that she needs to walk to get to a clinic. So it's that accompaniment, that having someone to hold your hand through it and to support you through it is one of the biggest challenges why people are not accessing healthcare in our country.
Thank you. Thank you so much for sharing that. So Nancy had another question. We're going to go back to the chat. This is for Lisa. Lisa, is there Medicaid reimbursement for any of the Healthy Start services, for example, doula services?
Yes, thanks. And I added some detail in the chat. This is a new way of thinking that most nonprofits most community-based nonprofits haven't figured out. California, there are a lot of restrictions around Medicaid, and usually the vast majority go to what's called federally qualified health centers, these institutions that have these kind of reimbursement pathways carved out. We don't have that yet, and to date, there haven't been a lot of opportunities for community-based nonprofits to participate. That's starting to change in California. Again, I'm so proud to be a Californian. We've expanded a lot of access to Medicaid, but also now on the back end, there's a new, for example, community health workers are now going to be the work of community health workers can be reimbursed, beyond clinical staff. So that's something that we're hoping to take advantage of. It's still really new, and we're looking for advisors who understand that system to help us figure it out. And we're participating in a pilot, but like everybody knows, Medicaid doesn't pay much. We know so many doctors and other clinicians that won't even accept it, right? Because the paperwork you have to do to get the reimbursement is an equal cost to delivering the service. So we're trying to figure out those systems right now.
Thank you, Lisa. Andy had another question for Thandi. You mentioned that rural young women often drop out of school, and so their job opportunities are limited. Can you explain some of the reasons why they drop out of school?
The number one cause of school dropouts for adolescent girls is pregnancy. There's a lot of unintended pregnancy. And then another key challenge with dropouts is, especially when it's to violence as well. Sexual violence or gender-based violence is another reason why a lot of our young girls also drop out from school. So those are the two key reasons. The third reason is, especially a lot of our young girls come from large families, and a lot of times in a large family, these are large families where they're usually raised by a grandmother. So a lot of the times they spend a lot of time at home supporting the grandmother to raise the other children. And so that's why some of them even drop out of school, so that they can have that parent take over that parental role.
Thank you. And I think this one's mostly for you too, Thandi. Are there WE programs in Botswana? So the women empowered programs. I know that's, we don't specifically have that program there, but obviously we are doing programs with women and girls. But if you want to talk any more about that, that question was from Norm.
Yes, actually, we do have any women empowered programs in Botswana. In fact, what we're doing right now as global communities working with our global office is we are adopting the Women Empower program for these young girls. So we call it We Save for Girls, where not only are we developing it for girls, but we're also developing it looking at the fact that they're so highly mobile. So we are also using the virtual platform and the in-person methodologies that we're using in safe spaces. And we're rolling out within the safe space to try and give them those economic strengthening opportunities as well.
Great, thank you so much. And I think Andy has another question. Could global communities join with other like-minded organizations like Planned Parenthood to increase our ability to lobby to get new laws increasing reimbursement? I think that's for you, Lisa.
Thank you. But two separate things. One, part of our Healthy Start project is what we call our Community Action Network, or CAN. And that is our initiative to engage partners to help us achieve our population goal. So we have over 40 agencies and over 100 individuals participating, including Planned Parenthood. So we get together on a regular basis to share updates and trainings, to collaborate and improve the system of care across partners in San Diego. Putting the lobbying piece, we receive federal funds, we're not allowed to lobby directly. We can educate, and we do sometimes participate in getting to know you meetings with legislators so they understand the importance of programs like Healthy Start. But that's something I'd like to see us do organizationally more, right? Understanding in the US context, well, actually globally, right? The funding follows the legislation. So as an organization, I think we can do a lot to understand better how legislative mechanisms will reinforce our goals to improve health really around the world. Just as an example, there's a big package called the Momnibus package. Instead of omnibus, it's Momnibus. It's a whole slate of ideas that we can embed in legislation to improve health outcomes. And so, certainly we can educate about the potential impact of legislation like that. But we would have a fine line to walk there.
Yeah. You mentioned that the organization that you're a part of can't lobby. Planned Parenthood has an action fund that allows it to lobby. So what you might consider doing is approaching Planned Parenthood, the CEO, Deborah Johnson, I know her, you can mention my name, and mention that, hey, there are some things that are really important to us that you may want to consider responding to and lobbying in San Diego. It can't hurt.
Thank you for that suggestion. I may return to you for for the connection. Thank you.
Thank you so much, Andy. Yeah, we appreciate any connections. And actually, that's a great segue into what I think I'm going to say is the last question. I'll say Norm's comment first, just so everybody can hear it. He just said, one of the things that I had hoped for Women Empowered, that it would become a platform for various kinds of interventions and instructions like this, and it's gratifying to see this. So thank you, Norm. We agree, and that's one of the great things, global communities and PCI coming together. We have this wonderful, PCI kind of brought the Women Empowered program and element into our programming, and we're excited to see it expand as well. So the last question I'll put out there is just, what can people do? What can, the average person do to help, help this situation, help what's going on? I know a lot of people feel like, I'm just one person and I just want to have something that I can do to help. So Thandi, why don't we start with you? What could people do to help?
Thank you. To scale up programs needs resources. And one very important resource is people. Our program is run on volunteers. So all our mentors are volunteers. And these young women also need mentoring. And another powerful resource that people don't consider is advocacy. Whether it's at community level, national level, internationally, we need a mindset change, one that will allow safe spaces for women so that they can be able to engage and learn about reproductive health. So for me, the two key ones, in addition to just financial resources, the power of people is something that really can go a long way.
Thank you so much. That's extremely important. I agree. And Lisa, what about you? What can people do to help? What do you think?
Thank you. Thandi, I love your answer first, let me say. I want to echo that. Starting from big to small, we're preaching to the choir here, but all those policy supports that we already talked about, being an advocate for paid family leave, Medicaid expansion, universal preschool, those are things that will create a strong safety net for families that will allow, health outcomes to change. It's shown that paid family leave decreases infant mortality rates globally. That's a known fact. Why? So we can do that. But you already all do that, I know. On a kind of more personal level, I would say to where we have the opportunity, each of us can offer coaching and mentoring to people from our priority underrepresented populations, right, to help them grow. And that can look like so many things, right? Somebody you already work with, somebody in your neighborhood. But I really believe that there's a strong component of empowering people from our priority vulnerable communities to grow, and they need allies and partners to make that happen. So that can happen at a really micro and personal level. And then the last thing, of course, resources, yes, human resources, but whether it's with us or at your local food bank, families do need help with really basic necessities. Could be diapers, could be food. We see a huge need, right? When we can provide a car seat for a family, that's $120 that can go for food. So things like that. Yeah, I'll stop there.
Thank you, Lisa. And thank you again, everybody, for joining today. We had some great conversation. I'm so glad that everybody was able to ask some questions, really important questions. Lisa, you and Thandi both, thank you for joining us and having, just educating our donors about what we're doing. I think it's really important. Even coming here today is something you can do, right? Coming to these webinars, understanding the work we're doing and continuing to support it. So yes, thank you everybody for joining us. And Andy wants
No, one more comment.
one more comment.
Yeah. Lisa, have you worked with Home Start in, say, San Diego? Because they do a lot of things that I think are aligned with what you want to do.
Absolutely, thanks. Yeah, they're partners. They participate in our community action network. We collaborate particularly on training, right? Raising the standard of care. One of my favorite workshops that we facilitated was how to better support LGBTQIA families, right? Engaging all types of families, right? Everybody these days is having babies. So we work together to train our staff on how we can better support those, that particular totally overlooked population. Yeah, they're wonderful. And we do have very similar programs. We do cross-refer when needed. And we participate in collaboratives to make sure that we're not duplicating services. So for example, I think right now we're the only agencies who has the capacity to serve Haitian Creole speaking communities. So they refer anybody with that background to us. And we know that they specialize, for example, in they have Swahili speaking language. So we refer Swahili speakers to them. We participate in those types of ways. Thank you. I'm glad you're very well connected.
That's great. Thank you.
Wonderful. Well, thank you. Enjoy the rest of your day, everybody. If you do have follow-up questions, I will send the video out. My email's on there. You can email or call or text or, and then of course, join us next time. I'm sure we'll have another one of these in a few months. So thank you. Enjoy the rest of your day and the rest of your week.
Bye.
Thank you. Enjoy the rest of your day.